Welcome to the AA Podcast, our little corner of the web where we are not afraid to discuss tough questions like,
when did nutrition, health, movement, and stress management become alternative medicine?
Where we embrace challenges in all aspects of life to become healthier and stronger versions of ourselves.
And where food and movement are the best kinds of medicine, and cooking meals at home is a revolutionary act. Hello, and welcome back to another episode of the AA Podcast. This is Ashley Olson.
Hey, and I'm Andrea Crade.
My video is frozen, and it's kind of a funny frame. We won't get into it, but yeah. So
Still
it's kind
frozen.
of a little
Still
frozen. Yeah, it's kind of a little distracting on our end, but it makes no difference to you guys, so I don't know why I brought it up. Other than that, that's why Andrea is giggling. But we are going to continue our discussion on low-dose naltrexone, which I hope you guys, if you haven't already listened to last week's episode, definitely do that first, because I had no clue what this drug was. Didn't know really what it was used for. I tried to listen to a few podcasts prior to recording this because I was like, what is going on with this thing? So it was really insightful and helpful to learn a little bit more about it. But today we're going to dive a little bit deeper. But before we do that, we are going to read our weekly Bible verse. And mine is coming from Psalms 34, verses 34. Psalms 34, verse 4, 5, and 8.
Ambitious.
Yes. I sought the Lord, and he answered me and delivered me from all my fears. Those who look to him are radiant, and their faces shall never be ashamed. Oh, taste and see that the Lord is good. Blessed is the man who takes refuge in him. It's basically natural Botox.
That's right. That's right. Yeah, mine's coming from Psalm 2. This one is Psalm 148:13. Let them praise the name of the Lord, for his name alone is exalted. His majesty is above earth and heaven.
Love it. So, Andrea, last episode we dove into what naltrexone was, how it kind of works. We didn't get into the weeds on that, but we also talked a little bit on the dosaging, some side effects, and even when not to take it. But today, why don't we dive into a little bit more on the what it can be used for?
Yes, I think that is a great place to start. I also just wanted to throw this out there as just to reiterate how well tolerated this drug is. So this is one of those and I'll tell you, I have a couple of pet prescription agents where I will just like, oh yeah, of course I will write a script for that. Because they're just so well tolerated. There aren't really side effects to speak of. And I'll just tell you, one of them is acyclovir or Valtrex, or these are the drugs used to treat cold sores, like herpetic lesions, right? They are so super well tolerated. Got a great track record. Just really an amazing. If ever there was a Nobel worthy pharmaceutical agent, that is it. And then low-dose naltrexone is kind of quickly worming its way into that category with me, where the benefits are just so great, and the risks or the downsides of the drug just are really minuscule. It's so well tolerated in most people. So anyway, I just wanted to put in another plug for just how safe and well tolerated this is. So yeah, so Ashley was mentioning, hey, let's talk about what we can use this drug for. And I think I mentioned last time, like, I'm sitting here having a hard time thinking about what it wouldn't be good for. Kind of like water. Like, what isn't water good for, right?
Yes.
And I know the irony of me talking about water, but yeah, like, drink water. It's good for you for a million reasons, right? That's so low-dose naltrexone, because it's modulating the immune system to down regulate inflammation via several mechanisms, then basically anything driven by where the pathology is driven by inflammation is going to be theoretically assisted by the use of this agent. So the first thing I want to talk about is long COVID. So boy, long COVID has been a real bugaboo to try and treat. It has caused some consternation, not only in my community, but also in the conventional community.
Mhm.
Often conventional providers don't know where to start with these folks. And I'll tell you, if you're listening to this, I'll tell you the first place to start. Number one, believe them.
Yeah.
That's the place to start. Believe the patient sitting in front of you.
Yep.
Anyway, I digress. I'm going to crawl off my soapbox now. I was just about to get up there, Ashley, and now I'm
Yep.
going to crawl. I'm going to crawl back down.
Get off.
I know. I'm down. All right, I'm down. But anyway, yeah, we can use this to treat this so-called long haulers syndrome. Okay, so because a lot of this stuff is driven by inflammation. It's driven by uh, episodes of microcoagulation, right? You get these tiny little thromboses or little tiny blood clots, and they can they can lodge in any of the microvascular you can think of, from things literally from head to toe, right? Like COVID toes. Do you remember when they were talking about COVID toes? Does that ring a bell for you?
Oh, very vaguely. I don't
Yeah. So
like lack of oxygen, right?
well, what we think it is these little micro clots lodging. Like, this is why the kidney damage.
Oh,
This is why the cardiovascular damage. This is why the respiratory um issues. This is why the brain fog, okay,
yeah.
is potentially because of these micro thrombotic events that are making these like little clots. The blood's getting sticky. You get an upregulation of platelets. And again, I'm sorry, guys, this is kind of again getting into the mechanistic weeds, but I love it. It's that once
It's
you
where
get
she
the
thrives.
that's where I live. So once you get this inflammatory response started, the blood reacts, right? Because inflammation is driven by components in the blood. And so one of the responses is to increase or induce the body to create more platelets. Now, platelets are these little bags of goo that make blood sticky, right? They cause some clotting. And so anyway, it's just long COVID. Back to long COVID. We want to help drive down the inflammation to hopefully recover some function. So these folks really suffer, and it can be anything from, like, a really bad case of tinnitus or ringing in the ears.
Mm,
It can be oh boy, orthostatic issues. So, like, profound dizziness. We see lots of POTS, postural orthostatic tachycardic syndrome, where someone will stand up and their heart will start to race, and they will have these episodes of syncope where they almost pass out, or maybe do pass out, because they just can't maintain their blood pressure when they change their body's position in space by standing up, right?
mm,
So yeah, there's a lot of stuff going on with this long COVID, but there is some data that exists from a few, intrepid providers that are using it and writing these case studies up and saying, hey, you know what? There's not really any side effects to speak of, and it's been shown to be helpful in these circumstances. So why on earth wouldn't you use it?
right.
Um, and so the next thing that I wanted to speak to was to get a little more to shed a little more light on the question that your friend brought up with regard to fertility. Okay, so we talked
Yes.
about male infertility last time, but and how that really, really needs to be checked, right? So if a couple is having fertility issues, I think a lot of times it's wrongly, that burden is wrongly placed on the female, but there are so many instances of low sperm counts in men these days. So you have to go down that road as well. But
Yep.
if you've got a woman who has PCOS, endometriosis, um, PCOS in particular, let's talk about that for a minute. It's kind of a scourge of PCOS, and again, we did episodes on this, so go back and listen if this is something that you are mired in right now. But polycystic ovarian syndrome is driven by chronically high cortisol levels, and also a feature of this syndrome is that often you'll see elevated blood sugar levels. That's why we use metformin in
Mm-hmm.
treating this disease, this syndrome. Um, so think about cortisol. All right. So if you've got chronically high levels of cortisol, cortisol is a steroid. Okay. So let's think mechanistically. Let's think like downstream. Okay, you got a bunch of steroid in the body because the body is stressed, right? So it increases cortisol. Now, most people know that these days because cortisol has been around in the public consciousness for, a good many years now. And so people know that stress equals cortisol. Well, what is cortisol? It's a steroid. It's like taking a ton of prednisone, okay?
Mm-hmm.
So your body is making steroid. Well, what does steroid do? We know steroids aren't good for us to take long term, but why? Well, one of the problems with steroid is that they will suppress your immune system. Okay.
Yep.
Steroid will artificially suppress your immune system. It also causes blood sugar to increase.
Oh.
So blood blood sugar increases are not good. They lead to, fissures in the microvasculature. They lead to chronically high levels of inflammation. Okay, so now we're getting somewhere with the PCOS. So with PCOS, we've got a relation to cortisol, we've got a relation to high blood sugar levels, and then further, we've got this downstream effect of kind of uncontrolled inflammation and chronic inflammation. All right. Now, your body, if you are in a high cortisol state, literally you're in fight or flight. Okay. There
Mm-hmm.
are only two gears. We have fight or flight, and then I like to call it feed and breed.
Okay.
So your body does not care. If it's in fight or flight, it thinks you are running from a triceratops, and it doesn't care about making sex hormones or babies. Okay.
Yeah.
So you are not in feed or breed. So not only are you not digesting food, but your body is like, what do I care about making sex hormones? I'm trying to stay alive. Okay.
Yep.
So that's kind of the milieu that's going around with PCOS. Okay. So yes, LDN, low dose naltrexone, it helps with inflammation. And so if it's inflammatory response that is at the root of PCOS, then yes, potentially it can absolutely help. But I like to think of it more as like another tool.
Yes.
Okay.
Yeah.
So I have lots and lots of tools. If you go back and listen to the PCOS episodes, there's so many tools that you can use to treat PCOS, and LDN is certainly within that arsenal.
Okay.
Okay. So I tell you what, let's go to autoimmunity
Okay.
next.
Yeah.
Because this, oh
Which we have
boy.
a whole amazing series. It was like
Hmm.
episodes 3, 4, 5, and 6, I think.
Yeah, that was way
Something
at the
like that.
beginning.
Yeah. To
Yeah.
go back towards the beginning, we have some amazing episodes on autoimmunity.
Hmm. Yeah,
But
so and autoimmunity has always been a pet area of mine. Like I'm keenly interested in autoimmunity. It's a really complex um complex physiology that encompasses autoimmunity. However, it is all, all, all driven by inflammation. So you cannot get away from inflammatory processes when we're talking about autoimmunity. The two are inextricable. They are intimately related. Now, that said, the very first thing, if I have a patient with autoimmunity, you best
Yep.
believe, what am I going to say, Ashley?
Get off
Thank
gluten.
you. Thank you. It's folks, it's a non-negotiable. It is a non-negotiable. There is nothing that I can do for you while you are still on gluten, because you and we've talked about this before. Again, I'm not going to retread old paths here, but you have to get off gluten. If you have autoimmunity, if you have runaway inflammation, get off the gluten. If you're not getting pregnant, did you know that there is literature out there, speaking of fertility? There is literature out there
Yes.
from other countries saying that
Mhm.
if you get off of gluten, like some crazy number, like 50% of these infertile women became pregnant after
Yep.
getting off gluten.
Mhm.
So please get off the gluten. I mean, just try it. Just try
Uh-huh.
it. It makes me crazy, the unwillingness of people to make a dietary change like that. And I
Yeah.
get it. Like, I get it. I do. You don't want to be that person, and I hear that all the time. Like, oh, I don't want to be that person that goes to the restaurants and I'm gluten free. You know what? People know what to do with that these days. They really do.
Yeah. I was just gonna say, like, back when it kind of first started coming around, like, it was
Yeah.
definitely one of those things. It was like, oh, that's weird.
Mhm.
But
Yeah.
but now there's just so many great
Yep.
ways that you can get off gluten. And I honestly
Mhm.
think we talked about this in talked to you about doing an episode on like beginning steps on ways to
Mhm.
quote unquote clean up your diet. So
Yeah.
I think we will do an episode on just some
We
simple
need to
things
do
that
that.
you can do that
Yeah.
don't feel so overwhelming because if you're
Mhm.
just gluten intolerant, that's
Mhm.
that's definitely more simple than if you're true celiac. But
Oh, yeah. Yeah. However, if you have autoimmunity, I instruct all of my autoimmune patients that, okay, we're going gluten free. Now, what this means for you is that when you go to a restaurant and they say to you, okay, is this gluten free? Is it an allergy or is it whatever? And you say, I am a celiac, because restaurants know what to do. You need them to take all the precautions that they take for a celiac. They
okay,
don't
yeah.
know what to do with, I have non-celiac gluten sensitivity. Okay. They're like, "Oh, okay, what does this mean? Like, if I sprinkle flour over your food, you're probably gonna be okay, right?" No, you're not gonna be okay. So, you need to, it's not for, restaurant workers that are just trying to get the food out. It's not for them to try and figure out the severity of your reaction.
Yeah.
It's up to you to tell them, "Nope, I'm a celiac." That
Yes.
just makes it easy for everybody.
Which again, go back to our episodes on this because Andrea goes into what the damage
Mhm.
is and how long it will take to recover from any
Yeah.
microdosing of gluten. But back off of
Yeah.
our high horse.
Okay. Okay.
So
So we're
we're
off
talking
gluten.
about yes. So we are
Or
off gluten.
yeah.
Now we're looking at
Mhm.
using naltrexone.
Yes. Okay. So, um in terms of which autoimmune diseases have a lot of literature around low-dose naltrexone, Hashimoto's, I use this with Hashi's patients all the time. If they have, like, out of control antibodies to their own thyroid, because I don't just run, a TSH every year. I don't just run a free T3 or a T4. I also like to look at antibodies every year. And so if they've got runaway thyroid antibodies, then I will absolutely use low-dose naltrexone. If they're off gluten and they're doing the other things, then we'll try that too. Also, MS, there's some really interesting data on using low-dose naltrexone in patients who have multiple sclerosis.
Mm,
Yeah, there's also use of LDN in patients with psoriasis, okay, which is pretty common.
Oh, yeah.
There's also a lot of literature on inflammatory bowel disease, which is, oh my gosh, if you're gonna have autoimmunity, inflammatory bowel disease, there are lots of devastating kinds of autoimmunity, and more being discovered all the time, frankly. Um, but I think IBD, or inflammatory bowel disease, which goes by the names of Crohn's disease or ulcerative colitis,
Mhm.
just
Yeah.
depending on where the damage is occurring. But I think this is one of the worst forms to have to deal with. It's just it can be devastating. Um and sometimes is in a conventional sense, not in a functional sense, but in a conventional sense, they'll tell you the only treatment is a surgical option where they remove part of your colon, or small
Mhm.
intestine, and resect the bowel back together. And that, that can leave you with ileostomy bag, for the rest of your life, which is, somewhat of a disability to have. So yeah, it's problematic. And short of that, the only treatment that they'll offer you are these immunosuppressive agents that suppress your immune system so vigorously that every single one of them, if you look at the side effects associated with them, they can either, one, activate other forms of autoimmunity, or
Mhm.
two, you see lots and lots of lymphoma cancers associated
Mhm.
with the use of these drugs too, because again, your immune system's, it does a whole lot more than just attack your own body. It protects you from infectious agents. It protects you from cancer cells that are, produced within your body. Our bodies are producing cancer cells all the time, but our immune system is able to track them down and dispose of them. But if you're
Mhm.
suppressing your immune system constantly, then you better believe you can develop lymphomas, different types of cancers that you can die from, infections that other people would not have an issue clearing. So yeah, it's a problem. Autoimmunity is a huge problem, and it responds incredibly well to functional interventions. So
Mhm.
you get off the gluten, um, try some low-dose naltrexone. If there, I can't see any reason not to try it. So Ashley was asking me about another form of autoimmunity, and I said, well, I haven't seen much literature on that particular autoimmune disease, but I told her, hey, if that was my patient, and this individual were doing everything that I had told them to do, and they're still having, we're still detecting symptoms, and we're still detecting antibodies in the blood, then you better believe I would try some low-dose naltrexone with that person. So yeah,
Yeah,
it's
because
a
like, again,
legit response.
when we talked about in last episode, it was like it's especially when you're dealing with an autoimmune issue, y- you want to get that inflammatory response down. And so, obviously,
Mhm.
the first steps are what Andrea is talking about. But if your body is still inflamed,
Yeah.
then it may just need that extra little help.
Yeah.
And also, what Andrea said in the last episode was that this compound is unique in the sense that it doesn't really act as a band-aid. It really kind of helps the body do what it's supposed to do.
Yeah. Yeah, and here's the thing. So I Ashley, you and I have talked about this idea of adaptogens, right?
Yeah.
We've talked about modulations, about compounds that modulate various systems in the body. And there are two examples that I can think of off the top. The first one is, I think we mentioned it in the PCOS episodes. We mentioned Vitex or Chase Tree, and I
Oh, yeah.
talked about it modulates hormones, meaning sometimes it'll raise something over here, or it'll lower something over here. So there's this idea of modulation, bringing something back into balance. The other time that we've mentioned this idea of modulation is in terms of like stress response, like high cortisol situations where someone is in fight or flight all the time.
Mm-hmm.
There are lots and lots of adaptogenic herbs like holy basil, tulsi, um, uh, you know, oh, for crying out loud. Phosphatidylserine is a bit of a modulator too. Yeah. Oh, ashwagandha. That's the one I'm
Oh
thinking
yeah.
of.
Yep.
So yeah, these modulating kinds of compounds, and those are all botanicals, but low dose naltrexone is it almost works as like an adaptogenic kind of way where it modulates things. It doesn't just suppress things, it modulates things. So it's a really unique and powerful compound. Um,
Which I'm
so
excited for more research to be done on it,
yeah, me
because who
too.
knows what else it's capable of doing.
Right. And in the meantime, again, like if there were tons and tons of side effects associated with it and it were dangerous in any way, then, yeah, we would all be eagerly awaiting side effects, but in the or awaiting research studies, right?
Mm-hmm.
To see where is it going to be worth it to use a drug like this. But like I said, it's so well tolerated that I'm just like, heck
Why
yes,
not? Why
let's
not?
try it. Let's
Yeah.
try it. Let's give it 6 months and let's see how we do. Um,
S-
so
So
I
yeah,
also
another,
wanted,
yeah,
yeah.
go ahead. Well, I
Well,
was
I
gonna
also
say the
wanted to
next thing on
mention,
the next thing
yes.
on the list was like we're talking about inflammation, and we just did
Mm-hmm.
a whole series on cognitive health.
Yep.
So the neuroinflammatory agent that it might be able
Oh
to help
boy.
with.
Yes. So things like Alzheimer's that are driven by, again, an inflamed brain, dementia,
Mhm.
Alzheimer's,
Mhm.
Parkinson's disease. So
Mhm.
there is some information out there about the use of low-dose naltrexone and Parkinson's disease and how it does provide therapeutic benefit. So I mean,
It's
come
like, why
on.
not? Try it.
Why not? Yes, absolutely. Now here is a particularly exciting place. Um, Pain syndromes. So acute pain, we can treat acute pain all day long. Easy to treat. This is pain due to like an injury, pain due to like you stabbed yourself as you were out in the yard, Ashley, trying to cut a branch or cut your finger off when you were trying to, do some yard work, Ashley Olson.
Yeah.
Um, and so that is an acute pain. Let's say you had, that gnarly ortho surgery I was talking about last episode. So they went in and maybe reconstructed your knee. That is an acute injury. Okay. That is an acute pain, and we have lots of great drugs that can treat that acute pain. But you know what we don't have? We don't have a lot of really good answers for this chronic pain,
Yeah.
especially the kind of nebulous pain. And I'm thinking about some of the pain syndromes that I see. So fibromyalgia kind of floats to the surface here. Fibromyalgia is this sort of diffuse pain that patients can't often pinpoint where the pain is coming from. It's just this sense of just being like, I'm just in pain. Now, a lot
Mhm.
of times they'll have tender spots, when you press on it. Oh, yeah, that hurts. That hurts. But again, there's no injury to speak of. So this is a chronic pain condition. In fact, there is a condition called chronic pain syndrome.
Mhm.
Um, and we don't our traditional opiates don't work on these things. So we end up using things like, oh my gosh, we use things like gabapentin, Neurontin. We'll use Lyrica or pregabalin. And these drugs are neuroactive. They're psychoactive compounds that were originally used for epilepsy. And this is what we're using to treat fibromyalgia and chronic pain. When we the functional space, we know that lifestyle changes really, really help with these conditions. And as well, low-dose naltrexone appears to help too.
Mm.
Okay, so and this is really where I see some of the microdosing used with regularity. So we talked about the dose being between like 1.5, working your way up to that 4.5 milligram dose a day. In the chronic pain syndromes like fibromyalgia or chronic pain, this is where I see a lot more of the providers playing around with like true microdosing. So
Mm.
like fractions of a milligram given a day. And then oh my gosh, there is one pain syndrome that is very poorly understood, very hard to treat. It's called complex regional pain syndrome, or CRPS. This is really a wild disorder, and it's very hard to treat. We're looking People are looking at like some really heavy duty psychoactive compounds like psilocybin, right? Like magic mushrooms, low dosing of LSD, things like ketamine, like mega doses of ketamine to treat CRPS. So think about those drugs and the side effects caused by LSD, okay? Psilocybin, ketamine, special K on the street, right? So these drugs make you dissociate, make you hallucinate, um, but we're seeing good responses to complex regional pain syndrome from something benign like low-dose naltrexone. Now that to me is really, really exciting because these people are suffering. Like they are
Yes.
really legitimately suffering
Well,
and
I'm
looking for some
thinking of my
answers.
grandpa. He's 93 and he basically
Mhm.
has spine degeneration.
Oh,
So he's
yeah.
in
Mhm.
extreme pain and like the
Yeah.
only time he's not in pain is if he's laying down. So like
Mm.
is something like this
Yeah.
something that could potentially help him,
Uh,
like
Potentially, I would
why
say, yeah,
not try
why
it?
not? Yeah,
Like why not
absolutely try
try
it.
it?
Now, and we'll get into this here just a little bit later. But in the elderly, there are issues with kidney and liver function, so you have to be able to metabolize the drug. So, um, liver function, kidney function needs to be at a certain level,
Mhm. Okay.
in order to use these. But yeah, I would absolutely try it. If everything else has been done, I don't see.
Does
Yeah.
it also need to be able to pass like liver and kidney through like a topical?
No, probably not. But would that help for I don't know a mechanism by which I don't know how much systemic absorption you get. So when I see the topical in use, it is in use in conjunction with the oral
Oh,
medication.
I
I
see.
don't see it used alone. Um, so yeah, but that's a great question. And it would depend heavily on how much systemic absorption you get, because if you get pretty hefty systemic absorption, then yes, you absolutely would have to metabolize it through the liver as well.
Okay. All right.
Yeah.
So what else can it be used for?
Well, okay, so this I think is really, really cool. So there are compulsive disorders that are all kind of grouped together under this compulsive activity umbrella. These are things like addictions, like opioid addictions,
Mhm.
like alcohol addiction, um, binge eating disorder. Okay. So people who have these compulsive actions that they can't control. Um, Low-dose naltrexone seems to have a really positive effect on these folks.
Mm.
And so you can time the dosing. Remember I said I usually have people take this drug between 9 and 10 p.m. so that I
Yes.
can kind of piggyback onto that endorphin hit in the middle of the night, 2 to 4 a.m.
Mhm.
Um if I'm using it for like if I'm using it for, say, a binge eating disorder, then I will ratchet that back to give me the response that I need during the, like, when is the patient struggling? Is it a nighttime thing? Is it a morning thing? And I will give the drug accordingly during that time window when I really need the effect. So yeah, compulsive disorders, because it's a neuroactive drug, right? It crosses the blood-brain barrier. It affects those mu receptors in the brain. It induces the brain to make more endorphins at these low doses. So I think that's a really, really cool action for these drugs. Now, another area of study that needs more research is sometimes this drug can be used for weight loss. Okay, weird.
Yeah.
But so think about this. If someone can't lose weight because they have like binge eating compulsions, right? We just talked about that. So that could potentially be a problem. But
Yeah.
I also want to think about, what about those people who are in like this chronically inflamed state? Well, it's extremely hard to lose weight while your cortisol is through the roof, right?
Mhm.
And so if we can have a positive impact on the inflammatory cascade and bring the levels of inflammation down, like measurably bring them down, then that can potentially contribute to weight loss. Okay. Now it's a very specific type of weight loss, but it's weight loss nonetheless. So yeah,
Yeah.
there is some literature out there on that.
That's pretty fascinating. So what
Oh,
about
oh,
oh, yeah.
actually there's one more. There's one more.
Yes.
Um, so I went out looking for, what about neurological issues related to inflammation, and specifically I was thinking about depression, because there's been a functional theory for a very long time that that an inflamed brain can lead to depression, that's
Mm.
probably one of the that probably has something to do with depression, okay?
Yeah.
And so, I actually ran across this study. They were recruiting for this study back in 2022, and nobody's published any results yet. So I'm really, really hoping that they got enough participants in the study. It was a very elegantly designed study as it was laid out, but they were trying to recruit people with major depressive disorder, um, to treat them with low-dose naltrexone and to
Huh.
see if they got any improvements. So, but like I said, I didn't see the follow-up results published. All I saw was the 2022 call for participants and the study design that they had. But they were essentially going to divide, participants into three study arms. Okay. So the first one, they were going to have two treatment groups. So these are the groups that would get the actual low dose naltrexone. And in those two treatment groups, they were going to divide them into either having a high CRP level or a low CRP level. And I'll tell you what that means.
Mm.
C reactive protein is a nondescript measure of inflammation. So we can measure CRP in the blood. So if I have a patient that, oh boy, if I have a patient that's looking, let's just give this circumstance. So let's say this female patient is looking sort of autoimmune-ish to me. I will order a CRP in her blood work, in her annual blood work, because I want to know, does she flag high for this kind of nondescript, non-specific marker of overall system-wide inflammation. Sorry, got a tickle in the back of my throat here.
You're
Um,
good.
so again, with this study, they were going to make sure that they had a whole arm that had high C-reactive protein. Then they were going to have another arm that did not have high C-reactive protein, but
Hmm.
still had depression. And then they were going to see what's the difference between the two. And then, of course, they were going to have a placebo group where that would just receive placebo or sham medication. So I'm really hoping that that study got done and that they are still kind of sifting through the data, um, and will hopefully publish. So
Yeah. But
I thought
again,
that was really
maybe
interesting.
not. But again, like with low side effects, if you are struggling with depression, potentially
Hmm.
it could be like, well, let's try
Yeah.
it.
Oh, absolutely. Absolutely. In people who are refractory to conventional treatments, like they're not responding to the things that we typically use, um, absolutely, I would try low-dose naltrexone.
So we've talked a lot about ways or reasons why you should or could take it.
Mhm.
But what are who are the individuals that probably should steer clear of it?
Well, so I alluded to this before, but patients who have liver disease or liver failure, if they have chronically high transaminase values in their blood work, so these are commonly referred to as liver enzymes like AST, ALT. If those are chronically high, if they have non-alcoholic fatty liver disease, if they have an enlarged liver, if they have certainly if they have cirrhosis or something or hepatitis, then this would not be the drug for them. So any kind of liver disease or failure. Um, then also, if there is any alcohol abuse going on or opiate abuse. Okay, so we've talked about this. Hey, I thought you said that this could be used for treating addiction disorders. It can. It can. But if someone is chronically abusing alcohol or opiates and they are not committed to stopping while being on this
Mm,
drug, then this is not the right therapy.
I see. Yeah, that
Mhm.
makes sense. So, how does one, since it is a prescribed substance, you're
Mhm.
like, this sounds magical. I want on it. Um,
Yeah. Yeah.
how do I talk to my doctor about this?
Mhm.
And, what does that look like? Because you're telling me this isn't necessarily a heavily researched
Right.
compound with all of these
Mhm.
amazing benefits for these things that we've talked about. So most
Yeah.
likely my doctor is going to be a little more hesitant if it's
Mhm.
your typical
Yeah,
PCP.
potentially
So
so.
what does that look like, and what are some tips that you might have with bringing up this subject?
Yeah, that's an excellent question because ultimately like you can learn everything in the world and then still not have access to this medication if it is if you feel like, hey, this might have some application for me. Um so first of all, I would say as with any communication with any human being, just just be respectful. Don't I there believe it or not, there are people who send emails to the office and they're like, "Hey, tell Andrea to do this." And it's like, "Oh, okay." Or tell her to write me this prescription or tell her to order this test. Um that just automatically puts somebody kind of back on their heels.
Mhm.
So you don't want to walk in there because honestly, like, I have a license to protect, and so I there are lots of things that I have to consider, um, before I write a prescription, before I order a test. Like, if I order this test, am I going to act on am I able to act on the results of this test, right?
Mhm.
Um, is this something that I know nothing about? Because
So
if it is,
yeah.
I own it once I order
Yeah.
it. I own it.
So if you haven't already, go back to our other episodes where we talk about what was it?
Primary
The
care.
primary on
The
primary
primer
prime
on primary care.
yes.
Mhm.
Because those were excellent episodes. The audio, I apologize, is not the best, but the information is amazing. And it was very enlightening to myself on
Mm.
how this whole world operates and how as a patient we can come in better informed and with a better attitude, um, to in how to approach these sensitive subjects, because you're right, you are another
Yeah.
human being. Like you believe with all your heart you have the best interest of your patient, and your
Mhm.
patient might come through with a curveball like this, and you're like,
Right.
I don't know how to answer that right now, and so their immediate
Right.
defense mechanism would be a hard no, whereas maybe
Mhm.
you can approach it a little bit softer, um,
Yeah.
and like even when you're scheduling your um appointment, be like,
Mhm.
I would love to discuss more on XYZ
Ashley,
because
yes. Yes.
I'm just learning out about it, and I
Mm.
would love to hear your feedback and what you know about it. This gives you as the practitioner
Mhm.
time to look at your
Yes.
patient's your patient's history to know like,
Mhm.
okay, they're perfectly healthy from what I can see. They do deal with XYZ. Okay, maybe they're dealing with PCOS. So
Right.
otherwise they're a healthy individual that with no real concerns. There is some
Mhm.
things that maybe this can help with her PCOS. So there's just ways that you can help
Yeah.
prep your doctor, and not just um,
Yeah.
blindside them.
Yes, and I cannot overstate what you just said is so perfect because there's nothing more frustrating for a provider than to have a patient tell the front desk, "Oh, I'm just coming in for, I'm just coming in for a checkup, just coming in to, you know, with nondescript information, right?" And then when I get into the room, I'm thinking, "Oh, okay, this is just a, hey, how are you doing? How are things going with the last things that we talked about?" And then
And
like I get
unbeknownst
this,
to you, they have a whole list.
oh my gosh, it happens. It happens and it's like, if I had known, because like right now, if I need to do some research on your behalf, because we don't know everything. Like
Yeah.
there's way more that we don't know than what we do know. I'll just tell you that. That secret is out of the bag. We don't know
Mhm.
everything. And we really want to help you. Like
Yeah.
we really do. We work really, really hard. Um and we are very passionate about helping people. Um but I don't have time in the middle of your visit to go research something, and I prep the night before for
Mhm.
my next day's patient visits. And so if you come in with something that I don't know about, then yeah, I can see where some folks, some providers might be like, nope, that's not something that I do. Whereas
Mhm.
if you had told them up front, hey, a patient wants to talk about the possibility or have a conversation about low dose naltrexone,
Mhm.
and if this might be helpful for them. Now, if you've got some grouchy provider that's just like, "No, this is stupid. This is not going to help you. I don't do this." Okay, vote with your feet and go somewhere else. Go somewhere else
Exactly.
where they're willing to have the conversation. Um,
Mhm.
but also they might say, "Hey, you know what? This really isn't in my realm of expertise. That's probably better answered by somebody else."
Mhm.
Then that's okay too. That's
Yep.
okay too. Go somewhere that's got some knowledge about this. But I always think it's a great entree to be able to say, "Hey, have you ever heard of low-dose naltrexone before?" Right? Like,
Yep.
that's a great way to start the conversation. And
Mhm.
then you don't assume that, because we don't want to disappoint you. And I'll tell you that that's a secret. We don't want to disappoint you. It's awful to like have a patient ask you a question and have us say, "Boy, I don't have a clue about that," and then see the disappointment in your eyes that
No.
I thought
Yeah.
you would know. I thought you would help me. We don't want to disappoint you. So give us a chance to prep, give us a chance to do a little research. And because we really do want to help.
Yep.
Now I would also say I would do a little legwork.
Yes.
ahead of time.
Mm-hmm.
Find a compounding pharmacy, because remember, compounding pharmacies have to make this stuff. And so compounding pharmacies, they're often privately owned. They are niche pharmacies. This is how they make their living, is through these compounds. So they are the experts, and they are often, you'll get some bad apples everywhere, but they are often very excited to talk with prescribers about the things that they have to offer, right? Because that's literally how they make their living. That's how they
Yeah.
stay in business. And so if you can find a pharmacy and just say, hey, could I talk to the owner, or could I talk to the pharmacist, and ask them, listen, okay, how much is your low-dose naltrexone? I'm going to have a conversation with my provider about this, and I'm just wanting to gather all the information I can. And do you talk to providers about prescribing information? Would you be willing to talk to my provider if they have questions? Can I pass along your info to them?
Mm-hmm.
And my goodness, if a patient showed up with that, I'd be like, thank you. This is amazing. Like, here is info where I can learn about this. And also, if I feel like it's appropriate for you, then yeah, I'll just send the script right over, because they're right
Mm-hmm.
there.
Yeah.
So anyway, that's how you approach it. And all that, you may do everything right, and your provider may say, no, that's not going to work for you. Go somewhere else. Get a
Yeah.
second opinion.
Yeah. Absolutely.
That doesn't hurt anybody.
Absolutely.
Yeah.
Well, Andrea, as always,
Yes,
you have
Ashley.
just
Illuminated.
enlightened my world to another
Oh my
degree.
gosh. Yeah.
And no, this was fascinating. And I
Good.
really do, like I said in the last episode, and I think probably the beginning of this one, was I do hope that there's more research on this, because potentially it could be a very helpful
Hmm.
and hopeful drug or compound
Yes.
for individuals that are
Hmm.
truly suffering. So,
Yeah.
um, again, if you have questions, if you are like, Andrea, I just want to talk to you. um, I need to talk to you instead of my PCP. Like,
Warn
maybe
me
there's some,
first.
yeah,
Yes.
warn her first. But,
Hmm. Yeah, there are ways to get in touch
there
with
are
me.
ways to talk to her in more depth. And, but also, like, if you have questions that the general public you feel like might have
Mhm.
questions on, please send them our way, and we will get those answered. But, um,
I mean, that's how these whole 2 episodes came about, was from a listener question. So, yeah, we really appreciate those.
yeah, so please send them in. And no, I'm a firm believer that there are no stupid questions. So, um,
Amen.
just ask away. Um, but as always, if you have enjoyed this episode or any of our other episodes, we would so deeply appreciate a share, whether that's to just a text to your friends and family, or maybe on your social media. But please do give us a shout out, as we would love to shout you out as well. Um, and as always, thanks for listening, and we will catch you on the next episode.
Bye. The content provided in the AA podcast is intended for informational and educational purposes only. The podcast is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. The information and opinions expressed in this podcast are solely those of the individuals involved and do not constitute medical advice.